welcome to the Valley. Today, I am your host, Janet Michael. It is Community Health Day, sponsored by Valley Health. That is the day every month we jump on a Zoom with a physician or an administrator, a nurse, a mental health professional, someone in the Valley Health sphere to talk about a health-related issue. March, as many of you may know, is Colorectal Cancer Awareness Month. So we are on the Zooms today with Dr. Michael Avery. He is a board-certified general surgeon specializing in colorectal surgery. He's based out of Valley Health Surgical Oncology at Winchester Medical Center. Dr. Avery, thank you for taking some time today to educate me and make me more aware of things I may not know about colorectal cancer.
Absolutely. Happy to be here.
So let's start with a little background. Tell me a little bit about yourself and how you ended up in this field in particular.
So I was born and raised in Charlotte, North Carolina, and medicine was not my first choice. It's something I fell into. None of my family's in medicine, but I got an internship at one of the hospitals in Charlotte and was able to see surgeries and be around physicians and be around surgeons and really caught the bug. And so decided to pursue that. I ended up doing my undergraduate at East Carolina University in North Carolina, and then went to medical school at a school called Campbell University, which again is also in North Carolina, which is going to be kind of a theme here. And then I actually ended up doing my residency for general surgery at Carolina's Medical Center, where I got that first internship that kind of sparked my interest in medicine. I did 5 years there for general surgery residency. And during that time, I got to work with a lot of very talented colorectal surgeons and really enjoyed the process of colorectal, not only the benign things like hemorrhoids and fissures, but really the ability to treat cancer patients. And the one thing that really drew my attention to colorectal is because we have good screening processes, which I know we'll talk about today, is that if you catch a colon cancer or rectal cancer earlier enough, it is treatable and it is curable. And those patients do really well afterwards. And so all that combined really piqued my interest in colon and rectal surgery in general. So I applied for a fellowship, which I did at UT Southwestern in Dallas, Texas, which was awesome. And then during that time, I was looking for jobs and happened to find Valley Health. And that's how I ended up here today.
Well, welcome to the Shenandoah Valley. So let's talk for a second about colorectal cancer, what it is and why raising awareness, particularly in the month of March, is so important. Give me some background on that.
Yeah, absolutely. So I think the thing to note is that colon and rectal cancer is the third most commonly diagnosed cancer between men and women. And unfortunately, it's the second leading cause of cancer death. And so just for some stats in 2023, because data always takes some time to get, over 150,000 people were diagnosed with colon and rectal cancer. And of those 150,000, about 50,000 die from that, which is unfortunate because colon and rectal cancer is something that we can treat. And so colon cancer at its very base is just an abnormal growth of cells in the colon or rectum. And that is the last part of your digestive system. And so over time, those abnormal cells, which can be sometimes polyps or non-cancerous growths, if they go undetected for a long period of time, they can turn into cancer. And that's why March is really important for colorectal cancer awareness, because like I said, this is preventable, and almost half of colorectal cancers are attributed to even things like modifiable risk factors, which I know we'll get into. So March is important because it doesn't make any sense that this is the second leading cause of cancer death when we have tests that we can do to catch these early enough to have these treated. And so that's why it's really important to bring awareness into it, because a lot of times these are sensitive subjects. People don't want to talk about their bowel movements. They don't want to talk about their bowel habits. That's a really sensitive subject. But it's unfortunate because there are things that we can do to help with those. And so really getting the awareness out there that we can treat these and we can help with these problems is really important in treating this disease.
When I have talked about this particular topic on past shows, we always talk about how important it is that screening saves lives. And you're right. So many people are afraid of the screening, if not what the diagnosis may or may not be after the fact. What do you wish they knew about the
Yeah.
screening in general? Let's talk a little bit about what that is and when should people get their first screen, so to speak.
I think things that are important to understand about screening is that the process over time has really changed. We have multiple different ways to screen for colon and rectal cancer. Now, obviously, the gold standard is a colonoscopy. There's nothing better than colonoscopy. It gives us an inside look of the colon and really allows us to take a really in-depth look to make sure that we're not missing anything. So that's the number one thing. Colonoscopies are the best screening tool that we have. And unlike other cancers, it is a test that can not only be therapeutic in diagnostic. So meaning if we find a polyp at the time of colonoscopy or we see a mass, those a lot of times can be treated with that test. And there's very few tests out there for cancer that are the two things combined, where we can do two things at one time, not only diagnose, but treat. But the other thing to really note is that for whatever reason, and again, these are all very sensitive subjects, if people don't want to get a colonoscopy, we have DNA tests, things like Cologuard now. We have CT scans that are very good at evaluating the colon. So we have ways to at least screen people for these diseases. And so the screening actually has changed. So a lot of people think for a long time it was 50 years old. Mm-hmm. But unfortunately, because of the rise and prevalence of young onset colorectal cancer, that screening age has moved up to 45. Now that changes based on what a patient and their family history might have. And so any patient that has a first degree relative that has had colon cancer, or a first degree relative that's had large polyps or anything like that, the timing changes. And so if you have a first degree relative that had colon cancer diagnosed, it's 10 years from that diagnosis. So for example, if you had a mother or a father or even a sibling that got diagnosed with colon cancer at 41, your screening timeline would be 31. And that just is because you have an increased chance based on genetics and genes and things like that. So I think all things considered, I think the number one thing to take away from all of this is that we have a lot of ability to screen with many different tests. And even if you don't want to get a colonoscopy right away, there are other things that we can substitute. Now, again, the gold standard is going to be a colonoscopy. So even if you do something like a Cologuard, which again is very easy and is very good, it's not foolproof, but it is helpful because patients like the ease of it. But if that Cologuard test is positive, the recommendation is a colonoscopy. But all those things together, I think the number one thing to recommend and harp on is that these are helping you prevent diseases to get worse and to spread, and again, really to be treated up front to make sure that we don't get to these more unfortunate conversations where we have spread of disease.
Are there symptoms or warning signs that people would have that maybe they don't understand or know that that's what it is?
Yeah, absolutely. So the most common presenting symptoms for any type of colon or rectal cancer, the number one is something called hematochezia. And in medicine, we like to make things very fancy and have fancy words. That's just rectal bleeding. So if you have rectal bleeding, that is the number one kind of symptom that we see. Abdominal pain is also up there, and then altered bowel habits, whether that's constipation or diarrhea. Those three things, when looked in conjunction, those are very prevalent in people that have colon and rectal cancer. And so if you're having rectal bleeding, or you're having abdominal pain, or you're having change in bowel function overall, those are really things that need to be looked at. Other things that we see a lot of times are iron deficiency anemia, unintentional weight loss, or if you have blood mixed in your stool as well. Those are all warning signs. And especially if you're over the age of 45, those are not things that should be ignored, because by ignoring them, you're only letting a potential disease process keep going. One thing to note too, with all these symptoms, regardless of age, all patients that have any of these symptoms, they really should undergo a prompt evaluation. And that's something that's become more difficult with the younger onset, is because if you have a 30-year-old or a 35-year-old come in and say, well, I'm having rectal bleeding, everybody likes to blame hemorrhoids. And while most of the time it could be a hemorrhoid, there are things that we need to understand, that this is becoming a younger and younger onset disease. And so not only should clinicians be really aware of that, but patients shouldn't try to ignore that and just brush it off, because unfortunately you don't want to think about those things. But again, if you're having these kind of constellation of symptoms, you really want to make sure that you're reaching out to your physician to get a prompt evaluation.
And that goes back to your point earlier about designating March as Colorectal Cancer Awareness Month, because it has changed so dramatically in just the last 10 years for who's at higher risk and the age of those people. You really do need to talk about it more, in the hopes that I like to think that we have done such a good job of talking about mental health in this country over the last 10 years that it doesn't have the stigma, still has a stigma, but not the stigma that it once did. And this is where we need to get this type of cancer into that arena as well.
Absolutely. Again, and it's always comes back to, always a sensitive subject. Again, no one wants to talk about their bowel habits and things like that, but by ignoring them, you're only pushing down the road something that could be potentially treatable.
You mentioned earlier that screening should start based on, in some cases, whether an immediate family member had already been diagnosed. But are there other risk factors, lifestyle, diet, things like that that people should be aware of?
Yeah, so really risk factors are a big deal. And obviously with the onset and more prevalence of colon rectal cancer, we're trying to figure out what is causing this and what drives this. And there's things that we still don't know, but we know there are some modifiable risk factors. Now there's things like family history and inflammatory bowel disease that you can't change. Those are just part of your DNA, and those can change the timeline on when you get colonoscopies and how often. But some risk factors that we also see that have been heavily researched are lifestyle. So things like being sedentary, not moving around, not having physical activity, that has been linked to colon cancer and rectal cancer. Diet, which is a big talk of a lot of things. So diet that's high in processed meats, red meats, refined grains, processed sugar. So actually there was a study that showed that people who have at least 2 or more servings per day of a sugar sweetened beverage, that was associated with an almost twofold increase in colon and rectal cancer. And so these are things that we can modify. Obesity is also one of them, which kind of goes back to diet. Overweight people, unfortunately, have an increased risk of colon and rectal cancer. Same thing with smoking. All these things together are modifiable risk factors that increase your likelihood of developing not just colon and rectal cancer, a majority of cancers. A lot of these have been linked to multiple different cancers, but especially colon and rectal cancer. And so really it comes back to, I think this is not just a thing for just colon and rectal cancer, but just life in general. You want to stay active. You don't want to be sedentary. Try to avoid obesity if possible. Obviously try to stay away and limit alcohol and tobacco consumption if you can. And those things give you a better chance of trying to avoid these colon and rectal cancers.
Let's take a break. When we come back, let's talk a little bit too about whether men are at a higher risk than women and maybe some of the advancements in prevention and treatment that have come up over the last few years. Can we do that in the next segment?
Absolutely.
Okay, we're going to do all of that when we come back again. It is Community Health Day, sponsored by Valley Health. March, of course, is Colorectal Cancer Awareness Month. So we are on the Zooms with Dr. Michael Avery. He is a board certified general surgeon specializing in colorectal surgery at Valley Health Surgical Oncology at Winchester Medical Center. We're going to come back and pepper him with more questions in just a couple of minutes.
This Tuesday, April Davis will change the world. She doesn't know that yet. All she knows is that she went to justserve.org and volunteered an hour of her time. Browsing through dozens of service opportunities in her community, April decided to spend her Tuesday evening serving dinner to mothers and their children at a transitional house. She doesn't know she'll be serving a particular mother and daughter who will be spending their first night in this home. April doesn't know that the hot meal she'll serve is the first this mother and daughter will have had in a week, or that the simple smile she'll offer as she serves them will help them realize that things are going to be all right. Which is why this Tuesday, April Davis will change the world. See the difference you can make. Sign up for service opportunities in your community. Visit justserve.org.
To the Valley today. I am your host, Janet Michael. It is Community Health Day, sponsored every month by Valley Health. March is Colorectal Cancer Awareness Month. So we are on the Zooms today with Dr. Michael Avery. He is a board certified general surgeon specializing in colorectal surgery at Valley Health Surgical Oncology at Winchester Medical Center. We learned a little bit in the first segment about the value of screenings for early detection of colon and rectal cancers. And now we're going to talk about who's at risk and why. Plus, Dr. Avery will tell us how those screenings and treatments for colorectal cancer have come a long way from our grandparents' generation. Let's talk a little bit about, are men at higher risk or women? Aren't cases on the increase in African American men, young men even?
So African American males have been shown to have an increase in being diagnosed with colon and rectal cancer. Males in general are more prone to having colon and rectal cancer and also having higher mortality rates for it. One of the reasons that men seem to be more kind of prevalent with colon and rectal cancer is they have an increase in visceral fats, like we talked about. Obesity is one of the links to increasing colon and rectal cancer. Men tend to smoke more and drink more alcohol. And so again, those all links, those are, again, one of the reasons that we see an increased prevalence in males. But again, one of the big things is also African-American populations. They have an increased risk of having colon and rectal cancer and young onset colon and rectal cancer. There's not great data on why them specifically. There's a ton of research going into all types of cancers, especially colon and especially rectal cancer. Because the unfortunate thing is that when we see not only African-Americans or males, but young onset colon and rectal cancer, they tend to be left-sided in rectal involvement. And rectal cancer can be pretty life-changing because it significantly changes your bowel function. And so there's a lot of research going into why is this happening, and especially why is it happening in younger generations.
over the last couple of years, there have been some pretty big advances in prevention and in treatment. You talked a little bit ago about Cologuard in particular. That screening mechanism probably has been huge in the last several years, but I'm sure that's not the only thing that's out there.
Yeah, and so I think having these new non-invasive tests, those dramatically improve detection. And so these kind of multi-targeted DNA tests, they're very sensitive, meaning that they have a high likelihood of detecting something off. And so I think some of this data shows that even between 94 and 95%, which again, the Cologuard test is great because if it's positive, you know for sure that you need a colonoscopy. Now, again, there's still that rate of kind of missing that. But again, the fact that we have these new non-invasive tests that are only going to continue to get better is really encouraging because it encourages people to get this done. And then other things that we have is not just in detecting and finding these cancers, but actually treating them. So there's things like targeted therapies, immunotherapy is a big deal. This more precision medicine approach where we have a lot of data at our disposal, where we can really hone in and figure out what we can treat these patients with to give them the best outcomes. I think the most important thing to point out is rectal cancer in general. Rectal cancer in general, probably 20 years ago, if you were diagnosed with a rectal cancer, you were told that you needed to get a proctectomy, so removal of your rectum. A lot of times that ended up with a permanent end colostomy, and that's very morbid for patients. Actually, surgeons led a charge to see if we can try to avoid that. And so now we do targeted therapies and something called total neoadjuvant therapy for rectal cancer that tries to do organ preservation, meaning let's see if we can avoid a surgery. Can we give you medicine that actually shows good clinical responses and have you avoid a surgery and do something called watch and wait? That is just one kind of data point on how far we have come in treating these different types of cancers. There's data that comes out of Memorial Sloan Kettering up in New York with all these types of immunotherapies for patients with certain gene disparities. And those patients have incredible outcomes with incredible response rates to that treatment. And so that's another reason why it's so important for these patients to get screening, because we have come so far and to the point where we're no longer doing these big incisions and removing your colon. We have different targeted therapies in different ways to treat patients now that have really good outcomes. And so I think that's the most important thing, is that we have so much research behind all of this to try to improve patients' lives and improve patient outcomes, that it's really of benefit to the patients to get screened and see if we can help them.
And I think that's the biggest thing that people should take to heart is how your grandparents were treated for these particular types of cancers is likely not at all the way that
Yeah.
this generation or the next generation will be treated. And that should help remove a little bit of that stigma and that fear as well.
Yeah, absolutely. We tell patients all the time the length of stay has significantly decreased for a colon cancer operation. I would say our group here at Valley Health, whether it's a left sided colectomy or a right sided colectomy, I would say our length of stay in the hospital is 1 to 3 days. We're no longer having people have to stay here for weeks and weeks on end. And we see patients back in the clinic in 2 or 3 weeks later, and they're back to work, they're back walking around. So again, it is a very treatable cancer, and one of the most treatable cancers with one of the highest success rates of treatment. If you're a patient who has a early detection of a colon cancer and you get a resection and a good outcome with no positive nodes or things like that, you have a almost 85 to 90% 5-year survival. And that's unheard of in most cancers. And so again, it all just links back to the reason we want to bring light to this, and the reason we want people to be aware is because if you are aware and if you get testing, you can be treated if something is found.
So let's talk about the colonoscopy a little bit more, because I feel like that's one of the biggest misconceptions out there too. People don't go have it done because they're afraid of what it is, and what they think it is may not be what it actually is.
Correct. And so, again, colonoscopy is one of the best tests that we've probably ever created for cancer, because, again, it is not only diagnostic, but therapeutic. So if you see these precancerous lesions or even these just small abnormal growths, you can remove them at the time of the colonoscopy. There's very few tests out there that you can get 2 for 1, where you're, again, getting something treated and also diagnosed. And so what people usually hear about colonoscopies is there's these awful preps and that you have to go under sedation, all things like that. Modern colonoscopies now are performed under sedation, where typically patients are very comfortable and they never remember the operation itself. You don't have to be intubated. You don't need a breathing tube, nothing like that. Maybe for certain cases, but for the average American, you don't need that. And so the preparation, while sometimes being inconvenient, there's multiple different types now. There's not just this 4-gallon jug that you have to drink now. There's multiple different ones with different flavors and different ways you can take it. And so the prep is only becoming better. And so it used to be, well, I don't want anesthesia and I don't want to take the prep. Those have all gotten better. And there's really becoming less and less barriers and less reasons why you should say no to a colonoscopy. Because again, if you get a colonoscopy and everything looks great, the recommendation is, for the most part, usually you don't need one for another 7 to 10 years. So doing something once a decade to maybe avoid having a colon cancer or a rectal cancer, maybe avoiding having to have these big operations is usually pretty worth it.
That was part of the conversation that I had with Dr. Flaherty a couple of years ago. We were talking about Cologuard in particular. And he also is of the mindset that the colonoscopy is the ideal situation, because he said, say you do the Cologuard and it does come back positive. So now you still have to schedule the colonoscopy, but now you've got a couple of weeks of stress and worry. Oh my gosh, oh my gosh, oh my gosh.
Yeah.
When it could have all been done in one fell swoop and you would have come out of surgery and been told by the doctor, hey, we found this, but we took care of it and you're good to go. He said, you're saving yourself stress and worry if you just get it done the first time.
Absolutely. And again, the colonoscopy will pretty much always be the gold standard. And they're even creating things with colonoscopies now that have better detection rates for these even smaller and smaller polyps. So the colonoscopy is only getting better. The prep is only getting better. The anesthesia is only getting better. And so again, the number one goal for any of this is we want you to do at least something, at least some type of screening test to make sure that you're taking care of yourself. But if you can get a colonoscopy, it's absolutely worth it, because like we said, it's one of the only tests that are both therapeutic and diagnostic. And if you get it done, you can catch something early or just be reassured that everything looks good and you don't need one for another period of time.
After that last show that I did with Dr. Flaherty, I had a friend who went and got her colonoscopy, and she joked. She said, hey, I heard your show and you were talking with one of the doctors from Valley Health, and I just want you to tell them that if you see them again, it was the best nap I ever had.
It is unsurprising how many people end up saying that. They wake up in the post-op recovery unit and they feel fine, and then they go have a big meal and be reassured that things are okay. It's only getting better and easier to get a colonoscopy.
So as we wrap up, since it is Colorectal Cancer Awareness Month, what is one thing that you hope every listener today walks away with? Is it a piece of information? Is it about prevention? Is it treatment? What do you want to make sure that they carry with them throughout the rest of this month and into their future?
The big thing to harp on is colorectal cancer is one of the most preventable cancers. But the problem is it remains the second leading cause of cancer death. And that just shows the gap that we have going on in not only just screening, but lifestyle modifications. So get a colonoscopy, get a Cologuard, get something. Screening can save lives, and early detection dramatically improves outcomes. And so if you can take anything from this, if you're having bleeding, if you're having abdominal pain, if you're having change in bowel habits, don't push them aside. Don't put your health on the back burner, because the longer you wait, the worse and harder it is to treat. We have the ability, we have the technology, we have the access. We should really be pushing to make sure that we're getting our screening, because this is what's going to save lives and really push things forward.
Dr. Avery, thank you for taking the time to give me some history and some education on this today. I do appreciate it.
Absolutely. I had a great time, and I thank you for your time.
I will be back tomorrow with a brand new episode of The Valley Today, a few minutes after noon, so meet me here then.